السلام عليكم ورحمة الله وبركاته. طلاب صف الرابع. We will continue with sexual disorder part 2. In the last lecture we ended with amenorrhea. So amenorrhea in female will continue with male hypogonadism. In hypogonadism, whether the cause is central or peripheral, the symptoms are similar with loss of libido, lethargy, malaise, and weakness because of loss of testosterone. Patient may also present it with gynecomastia, of course infertility, and delayed puberty. Because of low testosterone, majority have osteoporosis, and because testosterone is one of the stimulants for erythropoietin, so patient will or may have anemia. How we investigate male patient with hypogonadism? Testosterone need to be assessed correctly by fasting level at 9 a.m. If it is low level, it is hypogonadism. Then need FSH and LH to distinguish between hyper or hypogonadotrophic by measuring LH and FSH in random sample. How we manage male hypogonadism? Testosterone freely indicated if young men have significant hypogonadism in order to correct osteoporosis, anemia, and replace muscle mass and address the problem of loss of libido. But testosterone is not without a side effect. Testosterone therapy in adults should not be started until the possibility of prostatic carcinoma excluded. So before starting, we need to measure prostatic specific antigen in men older than 50 and monitor it annual. This is problem number 1. Problem number 2, hemoglobin concentration need to be checked periodically because androgen or testosterone will have positive effect on erythropoietin secretion, and increased erythropoietin will cause increased production of RBC by bone marrow and resulting in polycythemia. Next is infertility. Infertility is very common problem affecting 1 in each 7 couple of reproductive age. In women, it may result from either ovulation abnormalities or defects in the reproductive axis, or result from abnormality of the reproductive organs itself anatomically. So it is either hormonal or structural. In men, infertility may result from impaired sperm quality, meaning function, or sperm quantity, meaning number. So, investigation for infertility should not perform until the couple has failed to conceive despite unprotected intercourse for at least 12 months. Meaning, when a couple came to assess their reproductive or to assess for infertility, the first thing is to advise the patient for frequent unprotected sexual intercourse for at least 12 months before we trying to assess or looking for underlying problem. This is true unless there is obvious abnormality, like a female with previous history of amenorrhea and she is recently married. This problem needing no wait for 12 months. This needs to be addressed right away. In women, investigation should be preceded by history of menstrual cycle. In women with regular period, ovulation can be confirmed by progesterone, as we said previously, in 21st day of the cycle. and in women with regular menstrual cycle, ovulation is likely. If ovulation is confirmed, then we need to look for structural cause by transvaginal ultrasound or hysterosalpingography, which used to assess the uterine and uterine tube anatomy and the ovaries, while in male, analysis of seminal fluid to assess the quantity and quality is warranted. Causes of infertility can be divided into 3 categories. It is either female cause or male cause, or it's mixed, the cause from both male and female. Female factor responsible for 35 to 40%, mainly due to ovulatory dysfunction like in polycystic ovary syndrome, or many of the causes we discussed previously of hypogonadism, either hypogonadotrophic or hypergonadotrophic. While structural cause could be in the tube, the problem is a tubular dysfunction, like patient with a previous pelvic inflammatory disease, and on resolution it will end with stricture formation, so there is defect in the pathway for passage of the ovum, or there is tubal endometriosis, or patient previously has sterilization either with oophorectomy or by tubal ligation, or patient with a previous pelvic or abdominal surgery and result in adhesion, tubal adhesion. Then other structural problem could be in the cervix or uterine, which could be congenital abnormality within the uterus, like agenesis or hypogenesis of the uterus, big fibroid occupying all the uterine cavity, or previous treatment for cervical carcinoma, resulting in removal of the cervix or adhesion, and the sperm cannot pass. Finally, Asherman syndrome, which is a complication of dilatation and curettage, a frequently done operation, especially after abortion. While male factor responsible for the same percentage, it is either sperm abnormalities or structural abnormalities. Sperm quality or production can due to abnormality on Y chromosome and abnormal development of testis and sperm, could be due to varicocele, which is veins around the testis, and the high temperature of varicocele will impair the differentiation and maturation of the sperm, or could be one of the many causes discussed previously of hypogonadism. While structural cause could be varicocele, the same, so varicocele could cause impaired sperm production and maturation, and could cause mechanical obstruction to the passage of the sperm. Another abnormality could be congenital abnormality of vas deferens or epididymis, and patient could have congenital absence of vas deferens, like patient with cystic fibrosis. A lot of sexual transmitted disease could resulting in stricture formation, and previous vasectomy is one way of sterilization. In a few patients, about 20 to 35%, the cause could be unexplained or could be mix of many factors in both male and female. How we manage patient with infertility? Of course, management should be directed toward the underlying cause. So the most important part in the management of patients with infertility is to find the underlying cause. Next, gynecomastia. What is the definition? Gynecomastia is the presence of a glandular breast tissue in male. So it is not a large breast in male. It is enlargement plus a glandular tissue. So in obese patient, there will be normally enlargement of both breasts. How we differentiate between true gynecomastia and that resulting from obesity, which called lipomastia, simply by palpating the tissue beneath the nipple and the areola. If there is hard tissue indicate glandular tissue more than 2 cm, this is true gynecomastia. While if only soft tissue present all over the areolar region, it is fatty enlargement due to obesity, and we call it lipomastia. Gynecomastia results from imbalance between androgen to estrogen. Normally in male, androgen is more than that of estrogen. So the normal ratio of androgen to estrogen is more than 1. If the ratio reverses for one cause or another, gynecomastia will develop. So any cause that decrease androgen production or increase estrogen level will resulting in gynecomastia. Most common causes of gynecomastia are physiological. For example, a newborn babies has gynecomastia due to high maternal and placental estrogen level. So exogenous estrogen from the mom. Prepubertal boys also could have gynecomastia because estrogen level reach its full level before testosterone. Testosterone develop late in male. That is why prepubertal gynecomastia is common, because estrogen level first develop. And in elderly men, due to decreased testosterone concentration, could resulting in true gynecomastia. Gynecomastia is often asymmetrical. So asymmetrical gynecomastia not always caused by underlying malignancies. What is the causes of gynecomastia? We discussed previously physiological causes of gynecomastia, which is the most common in newborn baby, prepubertal, and in elderly male. Could be drug-induced. Most common drug causing gynecomastia are cimetidine, H2 receptor antagonist, digoxin, antiarrhythmic drug, spironolactone, potassium-sparing diuretic, and anabolic steroids. Any cause of hypogonadism can result in gynecomastia because hypogonadism leading to low testosterone and androgen will reverse the ratio. Sometimes androgen level is normal, but there is poor response in the tissue, so androgen resistance syndrome is another cause. Or when there is estrogen production excess. Estrogen normally metabolized by the liver. So in patients with liver failure, there is impaired estrogen metabolism, and estrogen will accumulate, and the ratio of androgen to estrogen will reverse, resulting in gynecomastia. That is why gynecomastia is common in patients with liver cirrhosis and chronic liver disease. Another cause of estrogen excess is estrogen secreting tumor from the testis, or human chorionic gonadotropin secreting tumor from testis or lung. How we investigate patients with gynecomastia? First, we need to confirm gynecomastia by doing breast ultrasound or mammography to confirm and to assess the size of gynecomastia and exclude if there is any underlying mass. Then we need to do random blood sample for testosterone, estrogen to assess the ratio, and LH-FSH, prolactin, and human chorionic gonadotropin looking for underlying malignancy. How we manage patients with gynecomastia? Most common is by correction of the underlying cause. androgen could improve gynecomastia in hypogonadal male only. In some cases, where underlying cause addressed but gynecomastia still presents, surgical resection justified for cosmetic reason only. Another problem in reproductive system is hirsutism, which is defined as excessive growth of terminal hair in androgen-dependent site in women. So hirsutism is in male. Hirsutism in female, where gynecomastia is a problem in male. What is terminal hair? Terminal hair, typically thick, pigmented hair, black in color, and has specific distribution, not generalized all over the body. This is opposite to villous hair, which is thin, non-pigmented or fair color, typically found all over the body and usually from childhood onward. So one should distinguish hirsutism from a condition called hypertrichosis, which is generalized excessive growth of villous hair. So first thing, in hirsutism need to confirm this is terminal hair, not villous hair. Black, thick hair in androgen-dependent sites, which is upper lips, mustache, chin, beard, chest, upper back, lower abdomen, thighs and leg, forearm. What could be the causes of hirsutism? Hirsutism occurs when there is excess androgen or testosterone hormone in female. So any cause that increase testosterone level or androgen could result in hirsutism. Example, polycystic ovary syndrome, congenital adrenal hyperplasia, or exogenous androgen use, or androgen secreting tumor, Cushing syndrome, or sometimes it is familial. How we assess? Start with clinical. The severity of hirsutism is subjective. A lot of females with hirsutism never complain and does not come to clinical attention, while some females with mild hirsutism come complaining of hirsutism. So it is subjective problem depending on patient complaint. Drug and menstrual history is very important. As we say, androgen use could result in hirsutism, and menstrual cycle, looking for possibility of polycystic ovarian syndrome, also important. Calculation of body mass index, looking for either Cushing syndrome or polycystic, both of them result in obesity. And finally, examination for any sign of virilization, which is female developing a new onset deep voice, breast atrophy, clitoromegaly, and male pattern of baldness. So, in gynecomastia, a male has high estrogen, there will be glandular tissue development in the breast, while in female with androgen excess, the reverse is true. The female will develop breast atrophy. These are signs called virilization. Need to be remembered. Deep voice, breast atrophy, clitoromegaly, and male pattern of baldness. Sometimes these are associated with excessive acne vulgaris. Any hirsutism of recent onset associated with virilization usually suggests androgen secreting tumor, although it is rare. How we investigate patient with hirsutism? Random sample should be taken looking for serum testosterone, androgen, prolactin, LH, FSH. If testosterone excess is confirmed biochemically, then the possibility of tumor should be excluded by CT or MRI of the adrenal and the ovary. How we manage patients with hirsutism? Treatment according to underlying cause. But in this case, if the patient underlying cause is polycystic ovarian syndrome, how we manage hirsutism in patients with polycystic ovarian syndrome? Most patients, because drug therapy or pharmacotherapy has delay response, so a lot of patients use cosmetic measures first, such as shaving, bleaching, waxing. More advanced electrolysis and laser for a small area like upper lips, chin, but we need to know it is expensive. Anti-androgen therapy could be tried, but only in a specialized center like subrotirone acetate, spironolactone, and finasteride. Because the main problem in patients with polycystic ovarian syndrome is insulin resistant, so insulin sensitizing drug like metformin and thiazolidinedione can be used but are less effective than anti-androgen. All patients need to advise about weight loss because it is one of the major long-term management in patients with hirsutism. Finally, precocious puberty. This is the reverse of delayed puberty, meaning the puberty occurs earlier than usual. So it is the early development of secondary sexual characteristic before the age of 9 in male or before the age of 8 in girls. It is either physiological or central. Central precocious puberty is due to early maturation of the hypothalamic pituitary gonadal axis, and thus it is gonadotrophin independent. It is usually more common in female, and no structural cause could be identified. So it is physiological. Only the clock is running fast, but no underlying pathology. While second part is structural, which is due to underlying abnormality in the central nervous system, which could be tumor in the pituitary or hypothalamus or surrounding region. It could be CNS infection or inflammation. It could be surgery or congenital anomalies. Thank you.